Title: Obesity Paradox in Older Sarcopenic Adults, a Delay in Aging, a Systematic Review and Meta-Analysis. Published in Aging Research Reviews, January 2024. Introduction. As we get older, our bodies tend to store more fat, leading to a condition known as age-related obesity. This can be combined with another aging-related issue called sarcopenia, which involves the progressive loss of muscle mass and strength, leading to functional problems. Sarcopenia is linked to various health issues such as falls, fractures, decreased mobility, depression, poor quality of life, hospitalization, and increased mortality. When sarcopenia is accompanied by an increase in fat mass, it's termed sarcopenic obesity. The prevalence of sarcopenic obesity is on the rise, affecting more than 1 in 10 older adults globally. Both sarcopenia and obesity individually reduce health span and lifespan, and when combined, they pose an even greater health burden in aging societies. Studies have shown that increased fat mass may be a more significant predictor of disability and poor physical performance than decreased muscle mass alone. However, there's controversy about the effects of overweight and obesity on health outcomes and mortality, depending on factors like age, sex, health status, and the method used for assessment. The common measure for obesity, body mass index (BMI), is criticized for not distinguishing between fat and lean body mass. The term BMI paradox suggests that higher BMI values may not necessarily indicate more fat mass. Some studies even suggest an obesity paradox, where overweight and obesity are associated with lower mortality risk in older adults and severely ill patients. Sarcopenia is diagnosed based on criteria like decreased muscle strength, muscle mass, or muscle function. The definition and diagnostic criteria for sarcopenic obesity vary, and while BMI is commonly used for obesity assessment, it may not accurately reflect the amount of fat. The question arises about the impact of additional obesity on health outcomes in sarcopenic individuals compared to those without obesity. This study aims to review existing literature and conduct a meta-analysis to evaluate the impact of obesity in sarcopenic patients on health outcomes, considering factors like age and assessment tools. The hypothesis is that, despite a worse quality of life, the mortality of sarcopenic obesity adults does not exceed that of those without obesity, especially in the older population. Method. We looked for information in databases like Medline, Embase, Scopus, and Central until February 20, 2023, to find studies about sarcopenia, muscle loss, and obesity. 2 investigators conducted the search using specific terms. We removed duplicate results and manually checked references of articles and reviews for more studies. We also used Google Scholar to find articles citing or cited by the studies we found. We registered our plan in the International Perspective Register of Systematic Reviews Prospero. For each study we found, we checked its quality using a rating scale called the Newcastle-Ottawa scale. 2 investigators independently assessed the studies, and if they disagreed, a 3rd reviewer helped resolve it. We analyzed different types of outcomes like continuous, survival, and binary outcomes. For continuous outcomes, we used the mean difference. For survival outcomes, we used the hazard ratio. And for binary outcomes, we used the odds ratio. We used statistical methods to combine results from different studies and explore factors that might affect the outcomes. Our analysis focused on community-dwelling adults, severely ill hospitalized patients, and cancer patients. We also looked at different follow-up periods and methods used to define obesity. We did sensitivity analyses to check if the results change when excluding certain studies. We explored the potential impact of age on the results and checked for publication bias. All analyses were done using the R program and specific packages. Result: We found 15,060 records in our search for information on sarcopenia, muscle loss, and obesity. After removing duplicates and screening the titles, abstracts, and full-text papers, we included 112 studies in our analysis. Among them, 65 articles, published from 2000 to 2023, provided data on 100,612 people with sarcopenia from 27 countries. The participants' ages ranged from 47 to 86 years. The studies focused on various health outcomes, including all-cause mortality, cardiovascular events, comorbidities related to sarcopenia and obesity, serum levels of lipids, and inflammatory markers, blood pressure, cognitive functions, depression, and physical function. The obesity assessment methods included body mass index BMI, waist circumference WC, bioelectrical impedance analysis BIA, dual energy X-ray absorption DEXA, and computed tomography CT. The study quality was generally high, with scores ranging from 4 to 9 on the Newcastle-Ottawa scale. For community-dwelling adults with sarcopenia, the analysis showed a lower risk of all-cause mortality in those with obesity compared to those without. However, this pattern was not observed in severely ill or cancer patients with sarcopenia. We observed an age-dependent effect, indicating that additional obesity might increase mortality risk in younger sarcopenic adults, but not in older ones. The results were consistent across different tools used for obesity assessment, except for studies using body composition measures DEXA or BIA, which surprisingly showed lower mortality risk in older adults with sarcopenia and obesity. Apart from mortality, we analyzed cardiometabolic disorders, finding higher risks of metabolic syndrome, diabetes, hypertension, and hyperlipidemia in older community-dwelling adults with sarcopenia and obesity. Physical and mental function outcomes, such as timed up and go-tug test, arthritis, bone mineral density, and cognitive function, showed mixed results. There were no signs of publication bias in the analysis. Overall, our findings suggest an age-dependent relationship between sarcopenia, obesity, and health outcomes, emphasizing the need for tailored interventions based on age and health status. Discussion. This comprehensive meta-analysis investigated the relationship between obesity and sarcopenia in older adults, aiming to discern how the coexistence of these conditions influences health outcomes compared to having either condition alone. Contrary to previous expectations, the study found that sarcopenic obesity did not increase mortality risk and, surprisingly, was associated with a 15% lower mortality risk, particularly in older community-dwelling adults. The impact of age was notable, revealing a potential delay in the negative effects of obesity on mortality. Different methods to define obesity, such as BMI or body composition measurement, showed significant results, while waist circumference did not. In community-dwelling older adults, so was linked to lower mortality risk, while severely ill patients with sarcopenic obesity demonstrated similar mortality risk to those without obesity. Despite obesity being a recognized cardiometabolic risk factor, sarcopenic obesity did not increase the risk of cardiovascular events or mortality in community-dwelling adults compared to those without obesity. However, sarcopenic obesity was associated with a higher risk of metabolic syndrome and related disorders. Physical and mental functions varied with sarcopenic obesity, leading to worse physical function and an increased risk of arthritis compared to those without obesity. Falls, hip bone mineral density, risk of osteoporosis, cognitive functions, and depression did not significantly differ between individuals with sarcopenic obesity and those without obesity. The study suggests that age-related changes in body composition may create a phase where higher fat mass and low muscle mass coexist, indicating a sarcopenic obesity-like phenotype. Mortality risk in severely ill patients with sarcopenic obesity was similar to those without obesity, challenging the assumption of additional mortality risk conferred by obesity in this population. The findings highlight the complexity of the obesity-sarcopenia relationship, suggesting age-dependent and context-specific influences on health outcomes. However, certain limitations, including variations in confounding factors across studies and heterogeneity in severely ill populations, should be considered. Conclusion: in our study, we looked at sarcopenic obesity, a combination of muscle loss and excess fat in older adults. Surprisingly, having obesity along with muscle loss didn't increase the risk of death, especially in older adults, a phenomenon known as the obesity paradox. This might be because some people age more slowly, experiencing age-related obesity later. We found that, in older adults, having obesity with muscle loss didn't worsen the risk of falls, heart issues, or cognitive problems. However, it did affect physical function, arthritis, and metabolic syndrome more than muscle loss alone. For severely ill patients, the impact of obesity on mortality was not clear, as their overall health condition played a stronger role. Our findings stress the importance of maintaining muscle mass in older adults to avoid sarcopenic obesity and its related problems. With sarcopenic obesity becoming more common globally, it's crucial to diagnose and manage it properly with standardized definitions, recommended diets, and exercise programs to reduce risks.